Thank you, Amit. I just like to invite our panelists, Nivedita, Kunal, Saik, Virender, Naveen, Rajiv, Vijay, for the panel discussion. Please sit. It looks better actually. People should know you. Vijay, please come. Ajay, you can come. Ajay, Naveen, please come. Saik. See, one of the indication is non-availability of the surgeon. So I think there are very few people on the stage, but there are many people actually, those who are involved in the MDT discussions, and that is a huge group actually we are talking about. It's a simple case, but I have combined with some other images to take everything in one case so we can talk about. So this is an elderly patient, which is ECOG 1 never smoker. He has a history of hypertensive, there are other comorbidities. He had a TB 20 years back, there is extrapulmonary tuberculosis, and there is now present with the symptoms of cough since 4 months. So these are the findings. So I think one of the radiologists can take it. Nivedita, you can take it forward.
Yeah, so I can see there are a lot of fibrotic changes attributable to the sequelae of tuberculosis, but I also can see one speculated nodule in the right lung, which to me looks suspicious on imaging. And also besides that, there's a right pleural thickening and effusion, I presume, if the mediastinal window is there. And also another nodule I can see in the right lower lobe, which again has a similar morphology showing a bit of speculations. So would like to do further,
So you would like to further investigate, you would like to see some other windows, because sometimes these are the only images that are available to you, and you have to opine on that.
If you can provide me windows, then fine. So that's a solid lesion and it looks suspicious to me, even again, all the more on this window. So I would like to at least go ahead further.
It has been reported that there has been a lesion, there might be chances that it might be tuberculosis, there might be chances that it might be neoplasm. Virender, Naveen and Vijay, so if that is the kind of reporting you have, so how will you like to proceed further in this scenario?
Hello. Sir, the thing is that the lesion looks suspicious. Obviously, Nivedita has said that. And lot of infective changes are there. And as far as history is concerned, patient has a history of pulmonary tuberculosis as well as TB of lower limb. So I would like to prove this lesion and get a biopsy done.
So, okay. Nivedita, are there any chances that you are able to differentiate on imaging what could be fibrotic and what could be the lung cancer, and what are the lung cancer symptoms, signs that you can see on the imaging, which will like having a high specificity that it is probably 90, 80, 75% chance that it is going to be malignant. So are there any specific signs?
So there are two signs as of now that I can see. There are speculations, first of all, in the solid nodule. Secondly, the pleura is a bit, retracted towards the nodule, which points more towards malignancy. I mean, so these two signs look in that nodule look a bit ominous for calling it just a benign and leaving it there.
So
I would further like to
there is a very nice paper on the thorax actually, which has talked about the pretext probability of a nodule. One is regarding the size. Second thing is about the speculations. If there are speculation, it is 80 to 90% chance that this is going to be malignancy, and if there are lobulations, it is around 60 to 70% chance that it will be malignancy. And it is more than 3 centimeters, again indicate that there is a chance it is going towards malignancy, apart from the smoking history and the history of the location, size, apart from size, there is a location of the tumor that is in the upper lobes. So all that will indicate that probably we are dealing with a malignant tumor in this scenario. So definitely there is a role of radiologist to look whether there is any malignancy is there or not, and if it is there, then its extent. And if it is there, the findings that might be there regarding which can affect the resectability of the post-operative course, or if somebody has given RT, the post-operative, the post-RT course of that. So the thing is that once we have known that probably there could be malignancy, we will look and decide that whether it is fitting into any of these criteria where we have to label the tumor size, we have to talk about other T descriptors, how far it is away from the carina, whether it is having any obstruction, it is having local invasions into the chest wall, diaphragm, mediastinum, or there are any satellite nodules, because every increase in the size of the tumor, the 5-year survival is going to be low. So, so what are the indicators apart from the speculation, this thing that will pinpoint towards that it is going towards to be a malignancy? So, so if you, Virendra, if you see these kind of presentations, in what are the scenarios you will see that it is going to be resectable, or you need a PET scan, and what are the scenarios in which you can straight away refer to Vijay for further workup?
So for deciding treatment, I think there are many factors that we have to look into. First thing is that patient's general condition, effort tolerance. Here there is a history of, in particular, if we stick to this case, this guy had a history of COX in femur. So I think effort tolerance is not going to give us good idea. He may be using stick or maybe limping while walking. So that factor is out. Now another thing is that looking at this lung window, I don't think his PFTs are going to be good enough. So again, surgical is little bit less likely in this case. But obviously, whatever said and done, if we want to treat or go ahead with curative intent treatment, we need a proper metastatic workup. So PET CT and MRI brain will be needed in this case. And then I think functional evaluation also, even if he's not for a surgery, if he's going for SBRT or any other treatment, I think Dr. Naveen and Vijay will also ask for PFTs.
So Naveen, I think if there is a rib involvement, vertebral involvement, and there is a local mediastinal infiltration, these are the areas where surgeons don't have any hold, and they might come you for either a curative or sometimes maybe a palliative therapy, and then straight away is likely the fourth image where there is a lot of mediastinal infiltration, there are a lot of nodal disease, very high disease burden. It will be directly referred to Vijay for the palliative chemotherapy.
Yeah, so I agree with what Virendra just mentioned. So not only the radiological picture, but we also look at the patient to see whether the patient is in a general condition to tolerate whatever treatment we are planning for. So if the patient has a very locally advanced disease where we are not approaching with a cure, then we wouldn't really over-investigate the patient, and whatever is minimally needed is what we would go ahead with. But in the same vein, I would also want to add about, something that is very rarely done in India because we don't see so many, is the treatment of patients without histological proof. So in the West, it is more common. There are a lot of case series, a lot of literature on this, where mostly these are patients who have been screen detected with malignancies. And what happens with these patients is they are serially monitored, and then they are found to have nodules which progress slowly over a period of time, and with that presumption that this is malignancy, these patients are treated, and there are a lot of clinical radiology models which are applied on these patients to see whether these nodules are actually benign or malignant. Use of artificial intelligence also in this matter helps. We always say that we need to have a histological proof because of the fact that there are a lot of other competing, other etiologies which we generally see in our country. But very rarely we do see patients who have radiological features of malignancy, but if they are unfit for any, even a biopsy, if they have such large emphysematous lung, then those patients we do consider for treatment without histopath, as long as we make the patient understand what they're getting into. But otherwise, all these patients, obvious disease involvement with locally advanced disease, because the further treatment, if they're especially suitable for, then we have to ensure that we get a biopsy so that we can biologically label them properly.
So second thing about the patient which we have started with, whether there is any biopsy indication in that before proceeding for any kind of management, or because there is a pleural effusion on the right side, should we test for the pleural fluid? And one question to Vijay, that if we are doing biopsy, whether we have to do ask for a biomarker status or PDL1 testing in the first go, or we will reserve for later on.
So the thing is, so the question is whether we would ask for a biomarker status in the first go.
Yeah. So I think
If it is,
the thing is that it is a 3 centimeter peripheral speculative lesion. We still don't know whether
Yeah.
there is any metastatic pleural effusion that is there, because there is definitely
So for
a
a
loculated
3
effusion.
centimeter peripheral located lesion, there is no significant mediastinal nodes. I would
So that is a
rather-
CT report finding.
Yeah. So I would rather for the final thing to come and then ask for biomarkers testing. If let's say that this was 4 centimeter, 4.5, or there was an N1, then yeah, definitely I would have asked for the at least for the mutation markers, and I would have actually asked at the same point for the PDL1 markers also, because now that there is data that we may use it or we may not use it. We have data from Checkmate 816 that neoadjuvant nivolumab can be given. We have data which have come for adjuvant immunotherapy. We also have now good data for EGFR mutation if there is presence to give this therapy. So yes, if there is an indication for adjuvant, which it seems to be on the scans, I would definitely ask for the markers. But if there is no indication for adjuvant, I would rather keep it reserved when it is required.
So it has been further worked up, and it was adenocarcinoma, which looks like to be, because it is peripheral, is speculated, and it is TTF1 positive. There was a USG cadet right pleural tap has been done, that is negative for malignancy. To Rajiv, how it is easy or difficult to differentiate adenocarcinoma from sometimes from the inflammatory lesions and sometimes from the metastasis from different sites on imaging? It might be that sometimes we can come across.
Yeah, so mostly if you correlate your histological features with imaging and clinical things, it becomes your diagnosis become very relatively easy. But there can be some situations where there is a florid reactive pneumocytic hyperplasia. Those situations can be little tricky, and especially on the cytology FNAC samples. But the biopsy is much more relatively more comfortable as compared to that. But there can be some situations, and in those situations you have to go back and discuss the case with the radiologist, and then rather than upfront offering a diagnosis. And another thing is about the ISCs. With the ISCs for TTF1 and P40 can clearly can very easily distinguish between adeno and squamous carcinoma. But if it is showing if the lesion is showing clear-cut differentiation, there is no need to even put the marker. You can save the tissue for molecular diagnosis.
Okay. Just to brief up everyone that the kind of staging for residents that are involved here. So to look for the just for the Virender, Nivedita and Sayak, so what will be the ideal option to stage these patients?
I would say PET-CT with or without MRI.
So that is something which is interesting. Now we have two options, option 2 and option 4. So
in the sense with PET-CT, if we had acquired a separate CT brain with high MA, low FOV, and a separate PET as well, if there is no metastasis in the brain in that, then we can go ahead with MRI. But if we can find a metastasis in that, then there is no need for MRI, because it's an asymptomatic patient with a
Yeah. So the other thing is that we have seen that the PET-CT they will do from skull base to probably up to the mid thigh or the knee joint, or sometimes they will the full, but they start from the skull base. So is there is any different practice that you follow, that you will start from the brain in case of lung, or you will start in all the patients where you will cover the brain?
So the practice we follow in TMH is we acquire from skull base and we take a separate CT plus a PET for brain. After the whole body CT and PET is done, we take a separate high MA CT for brain. That protocol we follow in TMH.
Okay. So
I just put that we would normally in our center do both PET CT and MRI brain, and MRI is just to avoid a futile surgery in case. In fact, the NCCN actually recommends even in stage 4 to do an MRI brain, because now that if it is driver mutated and if the patient is affording and if you have brain mets, then your choice of TKI would depend upon selecting a TKI which would have brain penetration. So I think MRI brain is required in nearly all stages of lung cancer now.
yeah, so thank you for that actually. The thing is, second thing is about how will you stage the mediastinum. We have seen the limitations of the PET scan regarding the negative and the positive predictive value both, and CT also has a limitation. So probably we need next level of investigation. Do we really need to stage the mediastinum? That is my first question, because this is a peripheral tumor. There are no obvious nodes on CT. There is no obvious uptake on PET CT. So do we have to go ahead and do the invasive mediastinal sampling first to Virendra and second to Naveen?
So T1 N0 on PET peripheral, we can avoid any sort of invasive mediastinal staging.
Okay.
That's the only case scenario where we would not do it.
Apart from that, the indication that we should go with the EBUS only in that scenario, and then mediastinoscopy. So we have known that the accuracy of the PET and PET CT, both in the different parts of the world, the sensitivity and specificity is around 60 to 80. The negative predictive value is pretty good, but the positive predictive value is relatively on lower side, on almost tossing a coin, where we can predict that this node is going to be positive or not. The other thing is about, we have seen about the invasive mediastinal sampling. The thing is that it is good to know the nodal status on the invasive mediastinal sampling. If there are no nodes, then directly surgery can be given, and then there could be, depending upon what is the size of the tumor and other things, the post-op chemo might be decided. If it is ipsilateral N2, then there might be need for neoadjuvant chemotherapy and surgery. And if there is a contralateral mediastinal lymphadenopathy, then sometimes depending upon the portals or whether the coverage of the node, we might give CTRT or palliative chemo. So Vijay, what are the indications of neoadjuvant chemotherapy when we are talking about the nodal staging?
So if at our center, if it is N2, then that is an indication for sending the patient for neoadjuvant chemotherapy.
So in N2, whether there is any specific this thing about the size, about the number, or about...
So Amit, what would happen is that a single station or multi-station N2 would come, but if the N2 is very bulky, or if the idea is, if you think that this patient would be a candidate for surgery, then neoadjuvant would be there. If you think that the patient is not going to be a candidate for surgery, at least N3, then it would go straight away to Naveen for chemoradiation.
Okay.
So the classical teaching is what Vijay is saying, that when patients have a single, N2 disease, and if the patient is a surgical candidate, then they would land up with neoadjuvant chemotherapy followed by surgical assessment, and any multi-station N2 would actually go for CTRT. But now with the availability of neoadjuvant immunotherapy, I think the horizon is kind of expanding. The indications are expanding. Even in multi-station N2, people have started doing neoadjuvant immunotherapy. We'll have to see it for further.
Okay. That we have talked about what we have seen, that this is, I think, our own TMS data, where if the PET uptake is more than 4, 80%, 18% of them are turned out to be granulomatous, and if we don't do any invasive staging, all these which have been grossly upstaged, received unnecessary chemotherapy and denied surgery. So this is just about EBUS and metastanoscopy. And what which about is MRI brain is necessary in all. I think he has clarified this thing. Different societies will tell mostly MRI is recommended by most of them, and there is an option for CCT, not for the PET-CT, but if we have a CCT component that can be used in scenarios with a lower disease burden. The other thing is that if we have asymptomatic brain metastasis coming with this particular setup, it is an hypothetical question here. So what are the different going to be seen? In the first one, where there is an solitary metastasis with ring enhancement. Second thing, where is a again subtle without any edema, and third thing, there is an leptomeningeal disease. So 3 different scenarios with the same setup. What is the different management it is going to be?
I'll take this. So not just looking at the scans, but we'll have to again look at various other factors. In lung cancer, we specifically look at something called as a GPA, the graded prognostic score, in which we look into the patient's general condition, patients, whether they have any neurological deficits or not. I know we are talking about asymptomatic patients, but this is what we generally do. We look at also the presence or absence of other metastases in the body, in the extracranially, whether the patient is controlled or if the patient is treatment naive, and also importantly, whether the patient is EGFR or any other driver mutant positive or not. So all these factors would play a major role in deciding whether this patient gets treated for the asymptomatic brain metastasis or not. So if I have typically a patient who's EGFR or ALK positive, and the patient is having a metastasis that is asymptomatic, and depending on what targeted agent the patient is going to get, if he's going to get a 3rd generation TKI, which has got a better CNS penetrance, we may actually keep this patient on observation. But if this patient is EGFR ALK negative and patient is being planned for systemic therapy, then we would treat this patient typically with radiation. So that radiation could be either whole brain radiation, or it could be just a focal stereotactic radiosurgery, depending on the number of lesions. So just to cut a long story short, it depends on various other factors, including patient-related factors and the disease biology per se.
Just to add to that, if it's a solitary, it would also depend on site, size, and what the patient preference are and what is the edema along. So if it is more than 3 centimeters, the neurosurgical thing will, if it is in the posterior, neurosurgery would be preferred. If it is in what we call as just setting of the motor area or then that would be that the radiation would be preferred in the such kind of choices.
So for the radiologists is that we have to talk about the size of the lesion. If it is asymptomatic, it is about the location of the lesion. It is producing any edema, causing any symptoms, whether it is single or whether it is multiple, and whether it is having a leptomeningeal disease. So these are the factors that has to be notified in the reports. So go about how to evaluate a case. We probably if I can go anywhere wrong, just please let me know. We evaluate with the chest radiography. We look for the disseminated malignancies there or not when we are talking about. And the role of CT, including with the upper abdominal CT, is to confirm a presence of a lung mass and the presence of any complication that is creating, whether there is any solitary or synchronous lesions that we are coming up across. Once we have localized the disease, we will see that whether the PET-CT has to be ordered. Once it is localized, we will try to look from the PET-CTs that whether there are any occult metastases there somewhere, and want to confirm whether there is an mediastinal nodal disease in non-enlarged lymph nodes that we are talking about, because CT can tell about the size and other characteristic, whether it is fatty hilum, it is having extranodal disease and other things. PET-CT we are looking whether the uptake and the distant metastasis. Once we know that we have localized this thing, both with the PET-CT and MRI, it is not showing anything, we will go with the invasive mediastinal sampling. We will look at negative nodes on PET-CT, normal size mediastinal nodes, and then we will further, if it is negative, then we will go ahead with the mediastinoscopy before doing a surgery. So this is the PET-CT of that patient psych, and it is showing this kind of uptake. Rest of the activity is not seen here. Looking at the uptake, can we tell that probably it is or we have to incorporate the morphological features of the CT scan?
Yes, we have to incorporate the morphological features of the CT scan, especially in these patients, which is a like known tuberculosis patient for 20 years, and so a flare-up of TB can also show a pretty intense uptake. But one thing is that all the fibrotic areas that were seen, those will not show uptake. So PET-CT is good in that way to rule out any other lung nodules that is probably due to past TB sequelae as opposed to a lung cancer.
Okay, thank you. So we have discussed these things, age, comorbid conditions, limited lung function status, borderline pulmonary and hypertensions. So now we have seen that there is no mediastinal uptake, it is EBUS negative, there is no brain metastasis. So just to Virender, whether it is an ideal candidate for surgery or whether Nivedita wants to do radiofrequency ablation or Kunal wants to do cryoablation, that is a different issue, and Naveen wants to do CTRT.
So looking at the lung window, it doesn't look like an ideal candidate for surgery. But yeah, I will get a PFT done at any way, so that if it is very low, then obviously I won't touch that guy and send to other modalities.
Is there a role of a lung perfusion scan before deciding whether?
No. So lung perfusion scan we will do, suppose if you are planning for a surgery. So there are multiple studies. If you are planning for a lobectomy, the PPO that you calculate with your PFT values or PPO that you calculate with the help of VQ is not going to alter your management. Or you want to go for a sublobar resection based upon VQ. But if you are planning for a pneumonectomy, then obviously that VQ is going to give you very valuable information. If there is a significant parenchymal involvement, or if there is a central hilar lesion, in that cases, that side of lung is mostly or not either non-functional or very less functional. In that cases, whatever your FEV1 or DLCO is there, that is contributed by normal lung, and that you can be very sure once you get a VQ value. So for lobectomy, sublobar resection, VQ has very limited role. It may give you a little bit of confidence that yes, PPO is going to be better, but not needed in all. But for pneumonectomy, yes, we do.
So this is typically the patient that he sends to us for RT, and patient with poor pulmonary function test, poor pulmonary function rather. So these patients are candidates for stereotactic body radiation, where so this is a medically inoperable early stage NSCLC, which is a classic indication for SBRT. So in SBRT, what we do is we do a high dose of radiation, which is focused on the tumor. The difference between the conventional radiation and SBRT being that we are delivering a very high dose of radiation with more precise techniques. We would not recommend CTRT in this patient because this we are presuming to be a T1 N0 M0. So here RT alone should be enough, although there is a lot of varying data on that. We could debate on that, but generally classically this patient would end up having a short course high dose radiation, which is SBRT. So if you ask me whether with this lung do I expect any complication if it is going to be different from another patient who has a pristine lung, again the data is little dicey there. Patients who have got pre-existing ILD, although we tend to give them RT because these are not patients who would anyway undergo surgery. So with the modern techniques, yes, we are able to deliver radiation safely. But the question is what happens to these patients 3 months, 6 months post-radiation, because with the radiation-induced pneumonitis is still a risk in these patients. They can develop radiation-induced pneumonitis after 6 months, even in a small lesion, and that small amount of radiation pneumonitis in an already compromised lung can tip the balance and make them symptomatic. So that's again a decision that we take in discussion with patients. But yes, so even in patient with ILD, we could technically do SBRT.
Navin, would this patient, if your attract proton would have started, would have taken it for proton?
I don't think proton would have any incremental value, at least in this patient, in this location. It's a peripherally placed lesion where photon-based RT should be
Would
good
it
enough.
decrease the added risk of pneumonitis?
Maybe for this patient again may not be, because as I said, it's peripherally placed, so it's still okay. But if I had the
Yeah. Please, you have any questions, please.
So I'll tell you, if the patient turns out to be AGF or ALK positive, na, I'll counsel the patient कि गोली लो और घर चले जाओ. I would do that, and I would ask Navin also if we can. Yeah.
But right now, we don't test patients at
Yeah.
the stage.
Initial question whether you send those EGFR for this kind of treatment. Because treatment is not indicated after SBRT.
I would agree with you. I would agree with you. In such cases, when there is this kind of, I would. Yeah.
Although there is not much of evidence, we do have patients.
The other question is if there are leptomaniac meds, do you do WBRT or you do radiation to spine also? And does the EGFR across all those driver mutation will change your decision? And how will you cycle with intrathecal chemotherapy if you are trying to do it?
So if the patient has only leptomeningeal disease and no parenchymal disease, then in those patients typically we don't advise RT at all. So these patients would go for either targeted therapy or intrathecal chemotherapy. But if patient has a coexisting parenchymal disease, we do treat only whole brain radiation. As you rightly said, craniospinal irradiation was something which was patients who had leptomeningeal disease. But if you look at the morbidity of treating these patients in such large fields, vis-a-vis if they are going to undergo chemotherapy, which CSA might compromise. So I would not really do that. Although there is, again, with proton therapy, with CSA, there is a lot of new interest in even in metastatic settings. So, but as of now, I wouldn't offer unless they have a symptomatic parenchymal disease.
What Navin was relating to that, this year in ASCO, there was a phase 2 study of proton CSI which actually showed that there is a DFS benefit, but it's yet to be confirmed in a phase 3. So if the patient has a leptomeningeal disease, and if this driver mutation positive and generation TK, there is very limited. We don't have a head-to-head. In leptomeningeal metastasis, there are only 4 randomized studies. All have been done in breast cancer. That's not a single study which has been done in lung cancer. At Tata, there is at present one going on, and it will be the first study in leptin, but I think it will get completed next year. To specifically answer to your question, if the patient is taking a 3rd generation TKI, whether it's a good brain penetrant, whether giving a intrathecal helps or not. If you are giving a 1st generation TKI, at least I would suggest that you give an intrathecal to the patient, because the penetration of a 1st generation TKI, CSF penetrations are really limited. Saying that, we have good data of arlotinib in a prospective study given in the regular doses, around 30% of patients CSF would get cleared.
Sir, if you don't mind, one small thing.
Yeah.
So coming to his first thing, where patient is ALK positive, Naveen and Vijay sir said, let's give that therapy. So my another point to add, or for my information, is that this lesion is curable. Either if he is not fit for surgery, SBRT. So if we see that STARS cohort, their 5-year survival with SBRT for a lesion which is 3 centimeter is more than 85%, if I am not wrong. I'm not very sure about percent, 90 or 85. If you see recently published 2 of the surgical trial where segmentectomy, lobectomy, even then 5-year survival is more than 80%. So why don't we treat this patient and keep on follow-up rather than giving that which is not very cheap treatment for 5 years, 6 years and then keep on following?
There is no debating that, Virendra. I think we would do that standard practice. We offer these patients either RT or surgery if that can be done. But what we are, I think, hypothesizing is that if our treatment has significant morbidity, in those patients, and if in the future, all these drugs are likely to get cheaper. So in those patients, possibly that's an option that, we have not been doing it because there is no evidence for it. And that the future is going to change as well. Standard is what we do, but it's likely to change.
So I think anybody have any questions? We have not discussed about RFA because there is a rupture trial that talks about comparison between the SPRT and RFA, and even that has a 3 years of outcome that is around 95% local control rates. So I think Vijay, if you have to add anything in that, please let me know. If anybody have any questions, please ask it. Our panelists are here. They can stay for 5 more minutes to answer your questions. So I think the MDT is over, and I will like to thank Vijay, Virendra, Nivedita, Naveen, Rajiv and Saik for their contributions to today's MDT. The thing is that I will try to incorporate all those things into a single presentation instead of discussing many cases, because we are not able to discuss many of these in the later half. So I have incorporated in between the different presentations in that scenario so we can discuss those cases. So thank you so much.